I'm Adrian Pick, one of the senior cardiac surgeons here at Peninsula Private Hospital. I perform a wide range of surgical services, both for coronary artery disease, for heart valvular disease, and also for thoracic surgical disease. But I think today we're going to focus on coronary artery disease, otherwise known as CAD, and also valvular heart interventions and procedures and techniques that we perform here, some of which are quite new and novel. So coronary artery disease is probably the major cardiac illness that we deal with here. Patients can develop, due to a variety of risk factors, blockages in their coronary arteries that can lead to either heart attacks, or they can develop symptoms of angina or reduced exercise tolerance. So they might be walking up a hill, they might get a little short of breath, or they might get pain in the front of their chest that can sometimes go to the neck or down the arm. Classically, if somebody's having a heart attack, it's described as a crushing pressure on the chest or retrosternal chest pain, like somebody's sitting on top of your chest. They might come to us either in an ambulance, in an emergency setting, or they might come to us because they've experienced some of these problems walking uphill or just don't feel as well as they normally would, and they attend with their cardiologist. A series of investigations are then done, either an ECG to look for signs of abnormality or a stress test, put them on a treadmill, an exercise treadmill or an exercise bike, see what happens when their heart rate goes up. Or we can go straight to coronary angiography, which gives us an anatomic demonstration of exactly what's going on in all the coronaries. And often what we see there are blockages, which can be focal or discrete. They might be just one or might be several vessels. And then there's a range of therapeutic options available to the patient. Most commonly, these lesions will be stented, and that means they can get an immediate relief of symptoms, but they then have to go on to two antiplatelet therapies to keep the stent open. They get followed up very closely, but that can just be an overnight procedure, which is very convenient. If they've got long segment disease, if a stent isn't seen or deemed by the cardiologist to be enough therapy to keep them out of trouble, then they might get an opinion regarding surgery. And if they need surgery, then what happens is they need to go to theatre. It can be done electively or emergently. The procedure can take 2.5 to 3 hours, and we can put as many grafts onto the heart as necessary, so that if you think of the heart as a pump and you think of the coronary artery supply as the fuel for the pump, then when you run out of fuel, the pump stops. The bypass graft goes beyond the blockage into a fresh, healthy part of the coronary anatomy. And we can do 1 or 5, 6, I've done up to 7 grafts on patients, so that at the end of the operation, all of that heart muscle has fuel, has good blood supply, and then regardless of what sort of exercise they want to do, they shouldn't run into any further problems. But that's a bigger undertaking for the patient. That's a commitment of 5 to 7 days in hospital, 1 to 2 days in intensive care, 4 to 6 weeks with a graduated rehabilitation program before they're back to doing pretty much near normal activities. But after that, they no longer have to be concerned about coronary artery blocking off or having a heart attack or getting an abnormal heart rhythm and even worse outcomes that can be experienced. Valvular heart disease, that's the other major component of what we do here. And there are 4 valves in the heart: aortic valve, mitral valve, tricuspid valve, and pulmonary valve. The pulmonary valve is rarely affected in adults. It can run into trouble in the pediatric setting. The other 3 valves we attend to in that order of prevalence. So with the aortic valve, the commonest abnormality is it will become stenosed, or it'll develop restriction to the 3 leaflets that open and close under normal activity with each cardiac cycle of systole and diastole. And when that opening becomes restricted, they can develop a gradient across the valve. Then the heart has to contract much, much harder to get blood out of the heart to the rest of the body. And again, the classic symptoms are that when you exercise, you can't do as much as you could do before. You become more short of breath. Blood builds up back in the lungs, and patients find that everything's more difficult. They become lethargic, they can get lightheaded, they can collapse on exercise. When we examine them, we can sometimes hear a murmur across the aortic valve. The best investigation to sort out what's going on is an echo, which is an ultrasound placed over the outside of the heart, which can identify all 4 cardiac valves and tell us whether they're stenotic or whether they're regurgitant, and whether there's any abnormality of their architecture. So with the aortic valve, we used to take all these patients to theatre and we'd replace the valve surgically. with valves that were constructed either from 3 leaflets from a pig's heart or from material taken from the lining of a cow's heart, which we'd fashioned together into an artificial valve contained within a rigid stent. And that would be sewn in. The patients would be placed on cardiopulmonary bypass. The aorta would be opened after the heart's arrested. Then abnormal valve taken out, the new valve sutured in, and then things are closed up. And again, at about a week in hospital and 4 to 6 weeks to recover. We now have a newer technology where we can deploy these valves through the groin, and that's called the TAVI procedure. And this keeps the patient in hospital for only 1 or 2 days. So it's a remarkable advance, really, provided that it is offered to the appropriate patient. Aortic valves can also fail to close properly, in which case blood, instead of just going one way through the heart, regurgitates back into the ventricle and has to be ejected twice or sometimes 3 times. And that leads to volume overload problems with the heart, which can then progress to failure. Again, we can fix that by replacing the valve so that it's competent again. That's not something that can be done with a TAVI at this stage. So that's the majority of the aortic valve pathology that we see. You can get infections of the valves, especially in IV drug users, and there can be changes to the valves related to a past history of rheumatic fever, which can lead to a combination of both those pathologies. For the mitral valve, which is the second most commonest valve we deal with, this often occurs in a slightly younger age group, and instead of 3 leaflets, there's only 2 leaflets. But the 2 leaflets are connected to the ventricle by very thin strings. With age, those strings can degenerate and they can just break. And if they break, then the leaflet just becomes flail, and again you develop regurgitation. So blood goes not just one way through the valve, but it regurgitates back into the left atrial or left ventricular chamber. And again, all the problems of ventricular overload. At this stage, there are no really good prostheses that can be placed percutaneously. That's a surgical solution that we need for those patients. And if they've got severe regurgitation, or if they've got significant symptoms, or evidence of significant left atrial chamber dilatation, or they go into atrial fibrillation, then we can do a mitral valve repair. And the traditional approach has been to go in through the front of the chest, make a sternotomy incision, to put a retractor in, put the patient on bypass, put a cross clamp on, empty the heart of blood, open it up, fix it, and then reverse that process. But now it can all be done with a very, very small incision just on the right-hand side of the chest, together with cannulation of the neck and the groin, with what we call minimally invasive mitral valve surgery. It takes about 2.5–3 hours again. The patients really are only in hospital for 4 or 5 days, and they're fully recovered after 2 to 3 weeks. And there's much less morbidity, much less pain, much faster return to work. So it's a much preferred option for the patient. The other mitral pathology that we see occasionally is mitral stenosis, and commonly this is related to rheumatic fever, which can affect all the valves in the heart. And if that's the case, often this calcification of the base of the mitral valve will need to be replaced. So that's, again, a surgical solution for those patients, but again, it can be done minimally invasively. And the last valve that we see is the tricuspid valve. It's called tricuspid because it has 3 leaflets. This is on the right side of the heart, so it's a lower pressure valve pathology. Traditional surgical procedures involved opening up the front of the chest and a week in hospital, 4 to 6 weeks to recover. These operations now can be done on the beating heart, and they can be done through a very small incision just on the right-hand side of the sternum, again with neck and groin cannulation. We isolate the blood flow into the heart. We can open up the right-sided chamber. We don't have to stop the heart beating to do the procedure. We can fix the valve and then take the patient off bypass. So there's no risk at all to their coronary circulation or of myocardial damage because the heart is never stopped. That procedure might take 2 hours. Patients in hospital again for only 4 or 5 days, but they're recovered after 2 to 3 weeks. So it's a significant advance over conventional surgery, and all those procedures are offered at this hospital. The first thing that patients often notice is they just feel a little bit different. Some patients might just have fatigue, easy fatigability. They might just be going to bed earlier than they normally would. They might find it a little bit more difficult to get up, 2 or 3 flights of stairs, depending on their age and their level of exercise tolerance. If they become more short of breath over months or weeks, that's noticeable. That's a key indicator. If somebody develops chest pain, which is in the front of the chest, it goes to the neck or the arm, and either it comes on at rest or at exercise, and that's an absolutely critical sign that with any of these symptoms, the patient should see their GP, and the first thing the GP should think about is there could be a cardiac problem going on here. So the enormous battery of tests that are available in terms of the cardiac workup. We've mentioned the stress tests for coronary artery disease. The echo can be done either from outside, or we can do a transesophageal echo, which places a probe down the esophagus and images from the back of the heart forwards and gives us a better view of the mitral apparatus and the right and left ventricular chambers. And there are other invasive tests that can be done in addition to coronary angiography. There's CT coronary angiography, there's nuclear medicine studies, there's MRI of the heart, all of which have certain advantages and indications in certain circumstances. But the critical thing is to get the patients that give us some of those pathognomonic clinical signs, make sure we don't miss them, and get them onto the investigative pathway so we can work out how best to manage them. Once we get a patient, if we think that their management pathway is not all that clear, or if we're doing a specialist procedure like a TAVI, that's a transaortic valve implant or valve replacement, some people call it TAVR, then we've set up a consultative meeting with a surgeon, with a cardiologist who specialises in that field, with a general cardiologist, often with a geriatrician and with a nurse coordinator. And we present all of the appropriate clinical information on those patients, and then we have a consensus opinion on what's the best management strategy going forward. And in some patients, it may be to do nothing. In some patients, it may be to proceed with specific interventions such as a TAVR. And in some patients, it may be that the preferred option is surgery, and then they can go down each of those pathways, and all of those findings and outcomes are discussed with the patient and their family directly. And then if they do go down one of the structural heart pathways like the TAVI, a lot of these patients are really old, they're really unwell, and often they're patients that wouldn't otherwise be offered surgery because the risks are too great. So it's important that we explain to them what the outcomes are and work out what the patient's objectives are in seeking a therapy for their problems, so that their expectations are not unrealistic. If we can increase our index of suspicion for the development of heart disease and get patients referred as early as possible, what's most important in restoring a patient's independence and their quality of life and their ability to perform all their activities of daily living is that we preserve their ventricular function. And we used to think that the later we refer patients for any form of intervention, the better, because all interventions have risks. We're at the stage now where most surgical procedures and many of the structural heart procedures come with very little risk, very, very low procedural mortality and morbidity. And that means that if we can intervene on patients earlier, we can preserve their ventricular function, we can preserve their cardiac performance potential and their quality of life. And it's diametrically opposite to what we would have recommended 10, 15, 20 years ago. So earlier referral is critical, direct consultation with your cardiologist or surgeon, and if you're not getting enough feedback about what's happening with your patient, then just ring directly, because it's really important that the GP and the patient are connected and aware of what's going on, and that's the intention of the service at Peninsula Private, is to provide that.